Hello, everyone. Welcome back to Luncheon with the Experts, the Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host. And if you're a regular to the show, you may notice a new setup. I have a speech later today for American Marketing Association, so I'm set up for that. But I decided to share it with you all. So let me know what you think. Hope you enjoy it. Anyway, if you don't know me, I'm your host and I'm a filmmaker, and I've been working with Carcinoid Cancer Foundation for almost 10 years to do things like this, to create video content, whether produced videos that we have published or live video series like this. And this program, Luncheon with the Experts, has been so fulfilling, something I've enjoyed so much. And something new for CCF over the past year. We've almost done this a year now, which is incredible. So if you aren't familiar with the show, stop by, say hello in the comments, tell us where you are signing on from in the world. We'd love to see how far this program reaches. And inevitably, every week we have people from all over the world joining us live. So that's really exciting. We'd like to thank Tercera Therapeutics, our sponsor. Without them, Luncheon with the Experts would not happen. We always like to give a disclaimer at the beginning of the program from them. And that said, that disclaimer is the opinions expressed by the guest presenters, as well as the questions asked by the audience that you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that last line is really the takeaway we want you to hear. We're going to give you some good advice, some general direction, hopefully answer some of your questions. However, we or our guest does not know your specific case. So take that information and that advice, bring it back to your home team who does know your specific case, and make the best plan for you moving forward. Now, today, I'm very excited to welcome our guest, Dr. Lale Kostakoglu. How are you, Dr. Kostakoglu?
Thank you so much. It's a privilege to be here. Thank you so much for inviting me. Oh,
I appreciate you saying that. Now, for those who aren't familiar with you and your work, could you tell us a little bit about what you do, where you do it, and also and how? I always like to put it like this: what is your role as you see it for the neuroendocrine tumor community?
Sure. I'm a nuclear medicine physician. I am currently the chief of nuclear medicine and molecular imaging at University of Virginia, Charlottesville. Before I joined UVA, I worked about 14, 15 years at Mount Sinai Medical Center at New York. And before then, that period, I was at Cornell, again in New York. So I can be considered a New Yorker, actually. So I did my residency training also in New York at Memorial Sloan Kettering Cancer Center. I also completed a fellowship after my residency in radio-labeled monoclonal antibody treatment. My career and research have mainly focused on the development of strategies involving PET-CT based advanced imaging to study tumor metabolism in various oncologic disease processes. I also have experience in targeted therapy, therapeutic radionuclides with a background, as I said, from Memorial Sloan Kettering. I have participated in both targeted imaging and antibody or peptide-based radionuclide treatments in multiple oncologic tumor subtypes. So at Mount Sinai, I have to highlight that I've had the privilege to have worked with Dr. Richard Warner very closely. Everybody knows. Pioneer in the field of neuroendocrine tumors, and he's also the founder of Carcinoid Cancer Foundation. Although he's retired now, he was the director of the Center for Carcinoid and Neuroendocrine Tumors at Mount Sinai, and there we have worked closely together with the entire group, and also significantly benefited from his experience. Basically, we were one of the first groups using gallium-68 loaded talc with our own IND obtained from FDA there, and served Mount Sinai patients with neuroendocrine tumors, imaging wise. And now we have participated in the expanded access research program for the lutetium 177 dotatate before the FDA approval. After his retirement in 2016, I again have had the honor to work with another authority in the field, Dr. Edward Wallen, and who's picked up the baton from Dr. Warner to be the director of the Center for Carcinoid and Neuroendocrine Tumors at Mount Sinai. We have expanded the already strong multidisciplinary team at Mount Sinai and started a very busy PRRT clinic there. So that's my background in a nutshell.
Got it. And for those that are tuning in who aren't familiar with Dr. Warner was the one who founded CCF in 48. I mean, it was about 53 years ago. That I might have the year wrong, but about 53 years ago. So we owe a lot to him. And I have had the pleasure of working with him as well. Up until within the past year or two, we've still worked together, and he is still doing, of course, he's not working in the field, but he is still very knowledgeable about this disease, and just a pleasure to work with. So everybody, let's go ahead and get the show started. If you're not familiar with Luncheon with the Experts, it's like a talk show. We have our guest on, we talk about the ways they serve this community, but a lot of it is driven by your questions. This is a really unique opportunity because it gives you a virtual one-on-one session with an expert, with a specialist, with a doctor in this field. So I'm going to ask you a couple of favors, which are ultimately going to benefit you. So you should want to do it. There's your incentive. One, if you know someone who would benefit from this show, tag them in the comments, share this video to their profile, get them here now so that they can get their question across if they have any. Of course, they can revisit and watch this video as you can later. You can go back to it, but it's not exactly the same as them being here while they can get a question across. If you know anybody who would benefit, go ahead and let them know. And the second thing I like to ask is, and you all have been doing such a good job of this lately, it really helps me do my job better. If you see a question in the sidebar that you also have, or you're also interested in, go ahead and like it or love it, or any of the reactions that Facebook gives you, the option to. Either way, it lets me see there's a demand for that question, and I'll make sure that we get it across to Dr. Kostakoglu. Because inevitably there are a lot of questions and we don't get to them all. So I want to make sure the ones that are in high demand I do get across. However, if we don't get to your question, I urge you to reach out to Carcinoid Cancer Foundation. You can message them here on their Facebook page in a private message, or you can also reach out to them at carcinoid.org, their website, and I promise you they will get you the information you need, or at least the person you need to talk to who can help answer that question. And finally, before we get started, I just want to ask, have you downloaded CCF's Net Cancer Health Storylines app? This app makes it very, very, very easy to record your symptoms, medications, nutritional concerns, moods, and more. So if you haven't, check out that app. We will put a link in the comments. And that being said, anytime we or Dr. Kostakoglu references an article or a source, a resource, anything like that you may want to jump over in your browser and open a new window to find out more information about, we're going to try to give you that link in the comments so that you don't have to go anywhere. We'll provide it for you, and then you can still enjoy the session without having to start a new window. So that being said, let's get into it. We see I've got some questions already rolling in, Dr. K, so we're going to go ahead and go. First one comes from Lynn. Lynn says, why is the USA FDA so much slower than Europe when approving medicines and treatments for NET patients? For example, alpha PRRT, and I know PRRT itself wasn't approved here until 2018. So any thoughts why that may be the case?
Well, thank you, Lynn, for this question. It is a little dicey territory to comment on that, but every country's regulatory is set in such a way that they protect patient safety first, and that comes first. Do not do harm is our oath, right? First, and that they have to make sure. So EMA, the European agency, is not necessarily easy either. I mean, you have to see their regulations, and they have stepped up over the past 10 years now. But the difference between, I guess, a European, not necessarily FDA and EMA difference, it's the European clinical practice difference. So when you go to a country, I won't name a European country, one of them, if you're an inpatient, they can do these experimental studies in these inpatients. Government allows and government pays for that. So that's a little different scheme here, right? You cannot do that in this country. So this may be changing there too. So it's easier to do clinical trials, not necessarily accepting a new molecule is easier. It's easier maybe to run, or faster to run trials. And also don't forget, these trials in Europe were not necessarily prospective trials, were thousands of patients investigated, but they were retrospective in the main part of it. So in order to get to the target with a retrospective study, you need thousands of patients. So I think the differences, not only the regulatory, the differences in how to run trials, what resources are out there for you. So that's all whole scope of the game. So I really have to give FDA in the acceptance approval process of Lutathera, for example. They did do this very fast, and they also allowed European data in it. There was this, NETTER-1 trial, phase 3, but they also looked into other patient data from Europe as well. And, NETTER-1 was run in mid-gut carcinoids, but FDA approved this for pancreatic also neuroendocrine tumors, PNET. So GEP-NET, the whole thing was approved with the existing data, not necessarily from this country. So I think that was a huge pace for FDA to have approved this product. But in order to get to the approval process, FDA's choices, they need phase 3 trials, which is the best way, randomized trials, to prove efficacy of a molecule and to prove safety of a molecule compared to the existing standard of care treatment. So that I don't know if I answer your question. There are lots of details to look into. We're only seeing the end result of it. So we are just saying, oh, it's so slow from the regulatory perspective. But, new molecules in any field development is very slow. There isn't any R&D money out there, research and development money. Some centers, academic centers, just took this on their own, with their own seed money, sometimes industry help, and most of the time industry help. And of course, grants from the NCI. It is very slow process. And this molecule, what is it, 20 years it took to approve with the first available data until the approval. So that's not unusual for other molecules, but I think the pace is getting faster compared to the past.
Got it. Thank you for that. And thanks for your question, Lynn. Next question from Jennifer. What is your experience with Lutathera impacting one's white and red blood cell counts? Is there something that can be done to increase the numbers within the generally accepted normal range?
Oh, well, the Lutathera is not unique in that sense. So this is a internally delivered radiation. So you're giving this systemically into the blood. And of course, the blood circulation will reach any organ, more predominantly sensitive ones in the bone marrow, because they are very active, multiplicating. Anything fast dividing like bone marrow cells will be affected by internal radiation. So that's not only Lutathera, any internally systemically given radionuclide treatment will cause hematologic toxicity first. Having said that, compared to yttrium-90, which was the previous radionuclide attached to DOTA, basically TATE or DOTA TAC, these somatostatin receptor analogs, it was much more toxic than Lutathera. Lutetium. Lutetium has a shorter range in the tissue, and yttrium has a longer range. So it is about, if you want to compare it, 2 millimeters for lutetium, for yttrium, 11 millimeters, so 5 times longer. So it would yttrium reach the bone marrow much easier from surrounding organs, and within the bone marrow reach more, sort of goes in the linear energy transfer, we call it, more linearly and more path lengthwise irradiate more cells. Lutetium is not like that. It's only 2 millimeters. So, and hematologic toxicity wise, no, we cannot do anything about avoiding that. But I wouldn't be concerned about hematologic toxicity too much with PRRT. You know, in NETTER-1, in the PRRT arm, serious adverse events in terms of hematologic toxicity, it was about 9%. And when you go into lymphopenia or white blood cells, it was about 9% in the high grade toxicity zone. So if you give, so I said I used to give monoclonal antibodies, and in that setting, this is so similar to any internally delivered radionuclide. The blood cells will go down starting 4 to 5 weeks after treatment, and then they start, they sort of reach a nadir, we call it, the lowest point, and then they start bouncing back, and it's reversible. And we don't see really in our clinical practice significant, which would require intervention, transfusion type of side effects. So they are usually mild. They recover from it. From each cycle, you're going to have the same sort of dipping down and going back up. So that's tolerated, well tolerated, we call the term. And there's nothing you can do about, like, think about chemotherapy. It does the same thing. Highly dividing cells like bone marrow cells, active cells, will be more affected by these molecules hitting the nucleus of the tumor cell inside the cell. So I think that has to be the way it is, but it is still very rare compared to other radionuclides. Lutetium is pretty benign.
Got it. Thank you. So folks, if you are just joining us or joined us late, we are here. This is Luncheon with the Experts. We are here with Dr. Kostakoglu-Shields, and we're already having some great questions. So if you know anyone else who would benefit from this, you can share this video with them on their page, or you can just tag their names in the comments. But we're going to keep moving forward because I see we have lots of questions, which is very exciting. Annette says, thank you so much for doing this each week. Greatly appreciated. Annette, we appreciate you. This is why we do this every week. All right, Dr. Kostakoglu, let's get back to some questions from Rebecca. How often do you suggest that we have a gallium-68 PET scan?
Oh, hi, Rebecca. That's a great question again. So, you know, the paradigm of treatment and patient management has shifted from just a department store, that's how I call it, to a boutique setting. So we're going from this one standard approach to everybody to everybody is different, individually different. Every tumor is different. Even the tumors within the patient individually, masses are differently behaving. So we cannot say this is the way it is for everybody, but it's just that there's a range.
Yeah.
If you are being treated on a, let's say, standard of care sandostatin, that's up to your clinician, obviously, but they don't necessarily do it unless they suspect a progression, a clinical worsening. There's no reason to do that.
Mhm.
And you're just unnecessary use of resources, one thing, unnecessary exposure of patient to a test with radioactivity in it. So those are the concerns, and expense is not small. If you're treated with PRRT, we definitely need a baseline gallium or copper right now available, labeled dotatate, to see receptor density, how well the tumors are expressing somatostatin receptors as evidenced by the grade of uptake. And once that's said, you go on to, and that doesn't have to be just immediately before. We accept it within 3 to 4 months, it's okay. Up to 6 months, it's okay before PRRT eligibility is set. So when you treat it, we don't require any gallium in between. It's a 4 cycle every 2 month treatment. At the end of 8 months, when you're completing the treatment, if there is going to be a test to be done to determine the response to treatment, that's not necessarily first line test, gallium 68 or copper 64 dotatate. First line standard of care is CT or MRI to check the tumor's shrinkage grade. So that's what we call RECIST criteria. It just needs to measure tumor and determines % decrease in size of the tumor. But if a gallium is done, in addition to that, that's perfectly fine. That's all the better. That gives us a tumor activity. So those tests are usually done after the end of Lutathera 6 to 8 weeks after the completion. So in between, we don't do testing, I said, but that's not your question necessarily. You're asking just a PET scan. I'm just adding this because it's in the same spectrum of testing. In between treatment cycles, if we need to image a patient, that would be a CT or MR to determine if the tumor is progressing. The reason we do that is usually it's done after the 2nd cycle, before the 3rd cycle. The reason we do that is to ensure a patient is not progressing on this treatment. If it is a fast progression, you may have to switch therapy from PRRT to something else. So that affects the management, but we don't do this again in everybody. If there's a clinical suspicion of progression, if the patient is very symptomatic, if there's any sign of progression, or again, complaint, pain, it depends on the patient, but that's when it is done.
So actually I have a follow-up question from Rebecca. How can we, the patient, make sure that we are receiving the sandostatin LAR injection correctly? And it seems like a lot of people have that question with her.
Could you rephrase that question? So how do you make sure LAR is received correctly? Is that the question?
Yeah, basically, how can we, the patient, make sure that we are receiving the sandostatin LAR injection correctly?
Okay, my take, I'll just explain my take of the question.
Please.
And if she could clarify if that's not the answer, please do that.
That's perfect.
So, PRRT, we give the radio-labeled molecule with the infusion of amino acids, about 3-4 or 5 hours sometimes. At the end of that, we do inject either sandostatin long-acting, LAR, or landriotide. They are some somatostatin analogs, so they are similar. At the end of our infusion of PRRT, that's what we do. Sometimes they can be separated, but they shouldn't be separated too much from the PRRT. It should be given within 2 days or several days at least, not with a big gap after PRRT. That can be done in your oncologist's office or wherever you have been having that. So that is part of the PRRT treatment, giving the long-acting sandostatin or landriotide at the end of the treatment. So that's a lumped up sort of bundled treatment. I don't know if that answered the question. So there isn't actually in between, like every 2 months we set these cycles. Every month, these NET patients receive long-acting. So basically, it gets rid of this in between LAR, this treatment. But if the oncologist feels that the patient should still receive after PRRT, we give the landriotide. Here comes another month, 4 weeks later, should they receive another long-acting? Or should they just skip that and go for the second cycle or the third cycle? That's oncologist's initiative. I can't dictate that term, but you know, in NETTER-1 trial, this in between long-acting octreotides or landriotides were not given. The phase 3 did not do that, but it can be done in especially highly symptomatic patients. Some clinicians prefer doing that, but that's again individually different. You need to discuss that with your physician. The only thing I can emphasize here is after PRRT, if you didn't receive the long-acting on the same day after completion of PRRT, you should receive the long-acting in the ensuing several days.
Got it. Thanks, Rebecca. If you have any other information on that or clarification, feel free to add that in a comment. We'll circle back to you, but thank you for both of your questions. Next question from Myra. What is your experience with affinitor given to patients with retroperitoneal mass near the portal vein and other blood vessels?
Right. So affinitor is chemotherapy. It's not my domain, and I would refrain from making comments about that. If you could refer that to your oncologist, that would be great.
Thank you. From Dorothy, for those of us being monitored 1 to 2 times a year, checking for metastasis and or tumor growth, which type of scan do you feel like is the best? CT, MRI, PET, something else?
So in terms of imaging studies, again, this is a general rule of thumb or general mechanistics, not necessarily specific to neuroendocrine tumors. MRI and CT are morphologic tests. They do lay out the anatomic distribution of tumor masses, and they are very good tools to measure size of tumors because they have high resolution, and you can delineate the border of tumors well. And you can also, with the contrast enhancement in vessels, see the relationship of the tumor with the vessel. It's not like lumped up in one bundle, in one mass. Vessels are separated. You can easily measure these tumors. Gallium-68 or copper-64 dotatate are functional tests. So they show you the receptor functionality and also density, activity of disease in a way. If you compare CT, MR, and PET scan with dotatate, any of these radionuclides attached to them, you're going to see maybe more tumor sites because these morphologic modalities rely on size criteria in measuring lymph nodes. And if they are smaller than 1 centimeter, they're not called out on the scans. But with PET scan, you can see a small as 3 millimeter now resolution within the context of neuroendocrine tumors I'm talking about, because they're highly active. So what is the best test? I would say a combination. So if you complete the treatment and you're being followed yearly, you're stable and just checking how you're doing, probably gallium or copper dotatate plus CT or MR. So MR is a better test for liver dominant disease because it looks at the liver parenchyma with high definition of soft tissue very well, delineates small tumors. CT is more for bone disease, for lymph nodes, it's equally good, and lung disease. Either, but if it is combined with a PET, that would be the best way of following up. If you are it's just one test you have to pick, which one that would be, I would go for probably PET scan rather than morphologic imaging, because there's so many residual masses which are inactive, and they wouldn't know if that's active tumor or not. In some scenarios. So PET scan would give you a better idea.
Got it. Yeah, thanks for that. And thanks, Dorothy. And there's a few other people who had that question, so I hope that helps. Next question from Edgar. This is one I haven't seen before. Radionuclides used in PRRT have a short half-life. How do you ensure that the chemical to be used hasn't been sitting there so long that it's lost some of its effectiveness? So how prompt do you have to be with the injection?
Radionuclide having a short life, Lutathera has a short half-life of 6.7 days. So that's not necessarily happening over the infusion period of 30 minutes. We infuse molecule. It's not even touching any activity of it within that period. So I don't think that is correct information. But if you're talking about a PET scan, that's different. So we have to differentiate that. Imaging molecules have short lives, lives for PET scanning. Gallium has hour half-life, 1 hour, and copper is 13 hours. But when you come to the zone of territory of therapeutic radionuclides, they're not that short-lived. Lutetium is 6.7 and yttrium is 2.7 days. So that's perfectly fine, actually, with delivery of the molecule.
Got it. Okay, thanks for clarifying that. And if we misunderstood your question, or if it was something else, just shoot us another comment and we'll try to get it to you. Okay, so Dr. Kostakoglu, we most of our patients are really educated on this, as you might be able to tell from some of the questions, but often we have a lot of people who are new to this disease. And actually, we have someone here, John, who is new to the show. Welcome, John. He says, hey, hi, Rain, we're new to this. What is meant by PRRT? So I know that we've been talking about it a lot, and John, you might not have been able to put all the pieces together because it's something that we talk about commonly here on the show. But Dr. K, if we could take a moment and just establish some foundation there for John and people like John who may be like, hey, what is this PRRT thing? And explain, just in simple terms, what that means, what it stands for, and what it does.
That's a great question. Thank you for giving the opportunity to clarify what that is. So PRRT is peptide receptor radionuclide therapy. That's what it stands for. It is a theranostic field. So you may hear this more and more, this jargon. So theranostic means therapy and diagnostic together. And the use of diagnostic procedures, selecting the appropriate patient population or individual patient, and treating it with the same molecule, but labeled with a therapeutic radionuclide rather than an imaging radionuclide. They are different. And then guide basically this way targeted therapies. So in order to do a theranostic approach, just like PRRT, you have to image the patient with the same molecule, going to map out the receptors, sandostatin receptors on the tumor, and see, yes, this patient has enough receptors and we can deliver sufficient radiation into the tumors, good eligible patient, and then continue on to the therapy with the same molecule attached to a therapeutic radionuclide, which has the ability to exert cell kill, DNA damage. And then we treat the patient with the therapeutic radionuclide, which is lutetium dotatate in this case, and its imaging arm is gallium or copper-64 dotatate. So they look at the same tumor distribution, and then one images, one treats the tumor. I hope that explained the concept.
Yeah, no, I think that was great. And John, I just want to say, first of all, welcome to the show. If you're new to this, we're here every week. So I would highly recommend that you tune in every week because we have a different expert. We talk about different things. And I appreciate your question. And this goes for everybody else. Please don't hesitate if there's a question like that where you need a little bit of that groundwork, because we talk about PRRT a lot. We talk about a lot of these topics a lot. And so it's kind of easy to slip, just slip past it like it's second nature to us, but it's not for all of us. So please don't hesitate if you're like, whoa, you guys are getting ahead of me. Like this is our job, is to break this down so that you can understand it and make it, easy for you to digest so that you can take it back to your home team, like we said at the beginning of the program, and find the best path forward for you. So also, I want to say that if you want to refer back to this video, it will live right here on the Facebook page. And for people like John or anybody else that's new, we have a ton of video content under the videos tab on the Facebook page. And starting Monday, we will republish this to YouTube so that people who don't have Facebook can access it. And we also have a lot of video content there. So if you are new to this, please take your time, scrub through the content that we have. We have a lot of it over the years, and we try to stay really up to date on that. And so our goal is to help you. So hopefully we have that information that does. And if we don't, let us know and we'll try to get it to you. Thanks again for your question. Next question from Tara. What is the average amount of time the sandostatin shots are effective? So how long can you be on it before it stops helping to slow the growth rate of low-grade neuroendocrine tumors?
Oh, I see. So that's a good question. However, again, that's a question for your oncologist, not for me, because I don't treat patients with unlabeled with other radionuclide on its sandostatin.
Got it. Another foundational question from Allison. Allison says, will you please explain the difference between octreotide and landriotide injections?
Well, I mean, they're the same somatostatin receptor targeting molecules, drugs. They are both drugs. Sandostatin is an older drug. Landriotide is a newer drug. However, again, that's a question for an oncologist, not for me. In some settings, landriotide proved better than sandostatin in terms of controlling the disease, but for the disease of an individual, everybody is different. I think that's a good question for an oncologist.
Thank you. From Bernadette, how long after each PRRT session will the symptoms of exhaustion last typically? And is there anything a patient can do to offset that?
That's a wonderful question. The fatigue experience after Lutathera is not specific to Lutathera. It's a generic side effect of any systemically, I should say, delivered theranostic agent or radionuclide treatment. Radiation has an effect on the normal cells. So it does create this fatigue. On normal cells, it has an overall effect like that. So it basically starts within 3 to 4 days. That's from my clinical experience of years, and lasts about 10 days, not more than that, up to 10 days. And you should feel better after. Your energy level should come back, even should feel better than before the treatment, I mean. There isn't much to do about totally negating that, totally avoiding that. But it also depends on your body's activity. If you keep doing sports, daily exercise, that really helps. And my patients kept exercising even though they felt tired. It's not really, they cannot get off the chair kind of tired. Right. And they felt better over time. So that it counteracts the effect, how active your tissues and your body is, counteracts the effect of tiredness in many settings. So I do advise exercise. You don't have to be an avid exerciser. I mean, you can just walk. Right. If you cannot exercise on a treadmill or anything. But don't tire yourself too much either, but keep active.
Yeah, I was actually going to ask that. I'm glad you mentioned that, because sometimes we talk about exercise and nutrition a lot on the show, and sometimes people are like, yeah, I'm tired, I'm exhausted, I can't think about going for a run or doing CrossFit or something like that. And I'm glad you brought up that point. It's like it doesn't have to be that, like, it's not binary, like doing nothing or running a marathon. So I really love your point. And anecdotally, at least, I hear from patients that just something like that, simply walking, is so helpful, just to get the heart rate up a little bit, get moving, and I think just getting outside is really helpful too. And we tend to hear that from patients. So I'm glad you made that point. Karen, I think this is a follow-up to a previous question. Should we do the PET scans, which I think you recommended, before our injections or afterwards?
Okay, so that's related to the sandostatin or landriotide injections monthly. So that clearance of long-acting, either sandostatin, LAR, or landriotide, is about 28 days. So you need to do the PET imaging at the tail end of that period, like you got an injection on 1st and 28 days later, 29th of May. From that, before the second injection happens, you should have in that period your PET scan. And for short acting, it's best you wean from it for 48 hours, but 24 hours is acceptable as well.
Dr. Kostakoglu, what's the most valuable lesson you've learned in your time of working with neuroendocrine tumors that helps you treat your patients better?
Dear, that's you can write a chapter about.
Let's go. No, I mean, what are, I can rephrase it if you want. Like, was there? Do you have something you were going to say?
No, I'm just gonna say, basically, if you're asking what is the best patient population to treat?
No, I'm just saying, was there a moment in your practice where something really was unlocked that helped you? And this could be a treatment that was, finally became available. But I find that when we look at trajectory over a period of time, there are usually these little moments, these little spikes that kind of happen. Was there something like that, or a lesson that you learned that helped you treat? Because this disease is completely unique, to most patients. What was there a moment that really things clicked for you that allowed you to serve your patients better than previously, or something you learned along the way?
Through just hands-on experience, if you're asking, I guess. Well, this is actually a continuous process for each patient. It's a better knowledge sort of is expanding. Well, I don't know if I could answer that clearly, pinpointedly.
Right.
But what I learned is you need to be attached to your patients. You need to have a continuous relationship with the patients for the period of 8 months. You cannot let them go. So what we do, and you have to also inquire about how they feel the week after and the following week until the next cycle, and then the cycle starts again. So that's a integration with the patient, with the patient's psychology also, and how to deal with all these side effects. They're sometimes very worried about side effects.
Yeah.
They're sometimes not enough worried about side effects. And how do you overcome fatigue? And if something developed in the interim, how do you intervene or address that unheard of side effect? I don't miss it. For example, leg swelling. It's not necessarily a known side effect for this treatment, but you have to be addressing that immediately. You can't wait. Now you have to contact your oncologist. You have to consult at the same time and make an appointment for the patient for a Doppler scan, for example, ultrasound, to see what's happening. Check the patient's cardiac performance in the interim. So it's like a dynamic relationship, continuously developing. For us as imagers, this is a new field because therapy has been picking up speed in solid tumors, especially these radionuclide therapies. But how do you integrate with you and own your own patient is a new field for us. And this is great because I always have had wonderful multidisciplinary team around me. Here at UVA, we have a wonderful team. We had it at Mount Sinai, and always interfering the situation with dynamic communication. So that's something I never probably did before, this active clinical care on the money every day. You have to be alert about this because there's so many, again, unlisted side effects you can experience from patients. Not only hematologic toxicity, not only renal function, already impaired patients getting worse, for example, how do you address? That's not it. So many unknown. Some patients just end up in ER with an infection, and they all tied to Lutathera, for example, which totally not related in many situations. But you have to be addressing these as a physician, and we have to do it very fast.
You mentioned how your multidisciplinary team has really helped you a lot. Can you talk a little bit more about the value of that, why it's so important, and even for people who aren't familiar, like what that means and who all sits at that table? But this is something that comes up a lot from different doctors and specialists, like the importance of having that multidisciplinary team.
So as you said, and as our patients are very well aware, this is a unique disease and everybody is different. And there's so many organs you have to check at one go. There's so many Also treatments and combination treatments and sequence of these treatments. How do you sequence it in one patient versus the other? It's so different. So multidisciplinary team, the oncologist, a GI physician, if that's the case within the team, and your IR, intervention radiology for liver-directed therapies, radiation oncology, nuclear medicine, other radiologists, pathologists. It's just, and of course, the biggest roles are on nurses, our wonderful nurses who are taking care of these patients. So you have to have this consult in an individual setting. What is the best thing to do? The patient comes with a significant liver burden, very small lymph node burden in the abdomen. Should we go for a liver-directed therapy, just shrink those liver tumors, or should we give PRRT? Should we debulk the tumor? Of course, surgeons, how could I forget? They are the main of the team too. Should the tumor be resected, debulked? So that is so significant. This is not one-dimensional work, really. It is almost up to 10 individuals deciding what to do about these patients. And I cannot emphasize how important it is for a disease surgically treatable in some patients, in metastatic disease, surgically, again, approachable. And a chemotherapy is another option for some patients, rapidly progressing patients, and a PRRT, of course. And how do we, and many other incoming biologic treatments, are they amenable to those treatments? So, and radiation therapy, the bone tumor, which is so big, is it gonna compress on the spinal cord? Should that be radiated? So that is a lot of details to look into for neuroendocrine tumors. I cannot emphasize this more importantly, more than what I have been saying actually. So this is not one person's dimension, one physician's dimension. It is a collective, multi-depth sort of addressing the situation platform.
Absolutely. Folks, we have just a little less than 10 minutes left. So if you have your questions for Dr. Kostakoglu-Shields, let's get them in now. Dr. Kaig, I'm going to keep moving on so we can get to some of these. From Sheila, could you please comment on the hematological cancers that sometimes show up comorbid with neuroendocrine tumors?
Yeah, so we are talking about MDS and leukemias probably. So that's very rare. It's 1 to 2%. 1 to 2% is such a small number. And also, you know, any chemotherapy, alkylating chemotherapy can lead to that as well. It's not only PRRT. So it is not necessarily only PRRT is causing that. And it is a very small number. I would not worry about that. And those are the patients usually, to start with, have comorbidities and have other diseases. Leukopenia, starting from leukopenia, low blood counts to begin with. So that's not only one, again, answer there, but it is a very small proportion. It's not that worrisome.
Got it. Thank you. And thanks for your question. Next question from Karen. I was put on beta blockers for high-low heart rate, and I have a PET scan in May. Is it okay to do the scan with metoprolol?
Of course. It has no effect on PET scanning, metoprolol. You can.
Okay, good. Thanks, Karen. Dr. K, we had talked briefly about different things that the patient can do. I think we talked about getting exercise. We've also alluded to the importance of them, finding and seeking out a center with a multidisciplinary team. And you had mentioned something about their psychology. And I know that this is something a lot of patients struggle with. Are there other pieces of advice that you have for patients from your experience to help maintain that quality of life? That's a term, a concept we always come back to, especially for NET patients, quality of life. Are there other things that you recommend for your patients to do to keep that quality of life as high as they can?
Well, that's again, it's a spectrum. Very deep, depressed patients versus just on and off feeling fluctuations of moods patients. So in a spectrum, if they feel down and if they need help, I really recommend to seek professional help first from a psychologist or a psychiatrist. Of course, mindful thinking is the name of the game for everything nowadays. If they can join those sessions just to relax, that would be great. Bring that up early on to your physician, because patients don't usually bring those issues up when they see physicians for neuroendocrine tumors or carcinoids. They only talk about their symptoms, but not necessarily how they feel. So they need to be addressing that internally and externally, voicing up and telling that to their physician. And again, within a multidisciplinary team approach, they can be referred to early on to a professional.
Yeah, I think that's such a great point. I am by no means an expert, but I do know that mental health and physical health are certainly tied together. I think that's a great point that you said, like, bring up how you feel. That's a big part of this. And I think it's just like the multidisciplinary approach, it kind of is for the patient too. It's not just one-sided. I think that's such a great point. From Edgar, we got time for just maybe a couple of questions from Edgar. Would you comment on alpha emitting therapy? I know we've touched on this briefly today. Could you elaborate a little bit more on alpha emitting therapy?
Okay, that's again another wonderful question. I don't know if you have time for addressing all aspects of it, but alpha treatments are going to be probably the future breakthroughs. The reason is, with these internally administered radionuclide treatments, the term you might have heard, linear energy transfer, basically a particle, radionuclide therapeutic particle traveling across the tumor. How much damage it can exert along that path length is dependent on how much energy they have. So linear energy transfer, we call it. Alpha emitters have a significantly higher energy loaded to them compared to beta emitters. It's about 400 times more if you're talking about in energy levels, like 80 alpha versus 0.2 to 2 beta. So that energy definitely leads to double breaks in the DNA, and beta energies like Lutathera molecule creates more on the single strand breaks on DNA. So single strand breaks, they can repair themselves over time. It may not lead to a cell death at the end of the day, but double breaks immediately a big damage on the cell, and it creates the cell killing process, tumors apoptosis, we call it, and that shrinks the tumor, that kills the tumor over time. Even it continues to exert its effect. So that, having said that, alpha emitters, dotatate, again, directed towards somatostatin receptors, will probably be the future. Drug development is very slow, as I said. So there is one phase 1 trial being run currently which is a lead 212 alpha emitter. So once that is completed, I don't know, maybe in the fall, they will then it has to go into phase 2 to determine the efficacy correctly. And if necessary, it's going to go into a randomized phase 3. So if FDA thinks this is just cannot wait for a long phase 3, it can be an accelerated approval process. So that all depends on the efficacy phase 2 trial results as well. So that's going to be probably 2 years at least, I'm seeing, even in the most accelerated phase. If not, it's going to be longer because phase 2s are hard to run. But having said that, looking at the pace Lutathera was approved and the phase 3 was run in this country, it may be very fast because this is a motivation of the patients being participating in a trial, and the physicians and the FDA. I think that can be faster than that. But again, another 2 years, probably we won't see much.
Got it. Thanks. And thanks for your question, Edgar. Karen says, thank you again, Dr. Kostakoglu and Rain, for hosting. I learned something new again. This is such a great resource for us. We are blessed to have CCF and you all. Thank you, Karen. I appreciate that.
Karen, you're sweet. Thank you so much.
That is what we're here to do. And that is our show for today, folks. Dr. Kostakoglu-Shields, thank you so much for your time. This was very informative and educational, and we really appreciate you sharing your time and knowledge with us.
Oh, thank you for reminding me. This is a great opportunity to be with the patients.
Absolutely. And send my thanks to Kathleen as well for helping coordinate.
I will.
And as always, we want to thank you at home for joining us. We hope that this program helped answer some of your questions. And if you have follow-up questions or you didn't get your question answered today, I reiterate that I want you to reach out to Carcinoid Cancer Foundation, either here on their Facebook page or at carcinoid.org. Thanks again to our presenting sponsor, Tercera Therapeutics. Without them, we couldn't do this show. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.